So welcome all to the 86th session of the Weekly Huddle. I'm your host Anoop, and joining me today is my friend and co-host Praneeth. We both are cardiologists working at Care Hospital. You guys know the general format of the Weekly Huddle. Today's case is very critical to cardiology, I must say. And many of the times, these cases are something which are clearly, I wouldn't say ignored, but brushed by because how stable the cardiac syndromes often are. This case also reminds me of the very first encounter that I had, I believe in 2017, when I was very new coming back to India. And at that time, I met an anesthesiologist who at that time was 45 years old. And he actually was a cardiac anesthesiologist somewhere in northern India. And he told me that a couple of years ago, he had an anterior wall MI and he underwent a coronary angiogram. That's at the age of 43. And he was diagnosed as having left main disease, for which he underwent CABG. But this anterior wall MI actually rendered him with moderate LV dysfunction. And he was totally asymptomatic on very minimal cardiac medication. And I asked him that, why are you not managing your cardiac medication aggressively? And he said, I'm feeling absolutely fine. I'm able to do all my work. I'm okay. I support in the operating room for 6 to 8 hours per day. Why should I change my medication? And at that time, of course, I also didn't have as much of confidence practicing in India. So that was just an initial introduction to me about heart failure therapy and the overall awareness in the community. Having said that, there are times when we do encounter cases like these where we ourselves hesitate a little bit to change an otherwise absolutely stable syndromes. So with that background, I'm going to discuss with you case for today, and then as our huddle goes, I will ask Praneeth for his initial opinion, and then I will take opinion from the attendees. So this is a 58-year-old male. I actually saw him just a few days ago. My first encounter with him was 2 years ago. At that time, he was 56, and he actually lives outstation. He came because one of his relatives stays in Hyderabad. So that's how he came to me, and his symptoms at that time, that was 2 years ago, were very classic of angina, exertional heart failure. And with some persuasion, we were able to run some initial diagnostics on him. His LV at that time was found to be severe LV dysfunction with ejection fraction of close to 30-35%, and symptoms absolutely suggestive of angina. He underwent angiogram, which showed severe triple vessel disease, following which he underwent uneventful coronary artery bypass grafting using total arterial revascularization. That was 2 years ago. After that, he recovered fine. He followed with a surgeon for a year. He did not come back to me. And in that 1 year, he was quite regular. He saw the surgeon a few times, and there were no any complications. Last time he saw a surgeon was about a year ago. And since then, he didn't have any other medical contact. He had been taking the same medications as was prescribed to him last year during his last visit with a surgeon. And with those medications, he had been doing absolutely fine. He is actually able to walk approximately an hour in the morning and in the evening. He does not have any anginal symptoms, no heart failure symptoms. He's able to do his routine activities. In fact, more than that, without any particular issue. He has a small business of his, which most of the time his family members look after, but he's also able to contribute without any major issue. His comorbidities include diabetes, which also he claims is fairly controlled, although he does not check his numbers at home as well. So this time it's a routine follow-up after a year, and he really doesn't have any active symptoms. His vitals in the OPD suggested blood pressure of 136/84 with a heart rate of 82, and those were regular. His ECG, other than old anterior wall MI changes, there weren't anything significant. His clinical examination was within normal limits. Routine laboratory findings were done, which showed LDL of 78. I'm just telling you pertinent findings. LDL of 78, his HbA1c was 7.3, and rest of the labs were more or less normal. His echocardiogram showed ejection fraction of 40%, and this 40% was same as last year. As I remind you, pre-bypass surgery, his ejection fraction was about 30-35%, which gradually improved to 40 in his first year of follow-up. And his today's echo was no different than his 1 year post-bypass surgery. His current medications include a combo tablet of clopidogrel and aspirin, that is 150 and 75 milligrams combo tablet that he takes daily. Rosuvastatin 40 milligrams daily, which he says that at times he's non-compliant, but for most part he takes it. He takes Vimeda, which is an ARNI, and that he takes 100 milligrams twice daily. He's on 1000 milligrams of metformin twice daily, and he takes 50 milligrams of vildagliptin once a day. That is his medication regimen. So the questions and the discussion for today's session is, would you change his medication regimen, understanding that if we go by the guidelines and the so-called GDMT or goal-directed medical therapy, other than Vimeda, he is not on anything for his heart failure. And then he, of course, is on medications for his coronary artery disease as well as for diabetes. So is there any change in medication regimen needed? And if yes, how would you go about it? Are there any additional diagnostics that will help you make the discussion, make the above decision? And in patients like these, this is what I started today's discussion was discussion, where they have good symptom control, but they are not on comprehensive cardiac medication. What should be our treatment approach? Should we be approaching based upon symptoms, as in, should our target be a symptom-directed therapy versus it should be a clinical or pharmacological goal-directed therapy where we have a certain goal to achieve regardless of how patient is feeling? So that is the current discussion that we are going to have. At the end, I will tell you what I did to the patient, but we'll open the discussion for the audience today. Praneeth, how would you take up this case? And then I will ask my rest of the attendees about their impression. Praneeth.
Yeah, good evening, everyone. This patient who has an atherosclerotic cardiovascular disease event with a severe LV dysfunction underwent surgery with some improvement in LV function, and currently he is in class 1 with some treatment. Now, there are two aspects which I look at this patient. One is to prevent a secondary prevention of an ASCVD event. And second thing is managing his heart failure, the so-called heart failure with reduced ejection fraction. For the secondary prevention of ASCVD, the most important thing is to target his risk factors. He has hypertension that needs to be well controlled, and you mentioned his LDL was 78. For secondary prevention of ASCVD, I want him or his LDL cholesterol to be slightly low, considering him to be still young. So I would, the target would be less than 55. Try to ensure that his compliance to high intensity statin is there, and if it isn't, then probably adding estimab, and equally having a word of discussion on or kind of introducing the importance of PCSK9 inhibitors. And his diabetes A1C is 7.3, reasonably okay, but if he's fine, I would still try to target his A1C to close to 7 or less without the risk of hypoglycemia. If I'm able to achieve that, I will try to be a bit aggressive in managing his diabetes as well, considering again he's less than 60 years of age. And now coming to heart failure with reduced ejection fraction, the goal is to give the maximal tolerated doses as much as the patient can tolerate it. And right now, our understanding is that all patients with heart failure with reduced ejection fraction should receive the so-called 4 pillars of heart failure therapy. The one, the RAS blockade with ARNI being currently having a class 1 recommendation. A beta blocker among the 3, either a metoprolol succinate, carvedilol, or bisoprolol. These are one of the 3 beta blockers. The patient is already on metoprolol. I would try to increase the dose as long as he can tolerate, targeting his heart rates somewhere around 60 to 70. Arni, he was on 100 milligrams if his BP permits, and I'll try to go to 200 twice daily. That was the dose that was used in the trial, the landmark trial. So I will try to increase it. Uh, Patient is not on any mineralocorticoid receptor antagonist, so I will try to include one of them. And lastly, because he's having diabetes and also irrespective of his diabetes status, an addition of an SGLT2 inhibitor. The most important challenge I see in this case is getting the patient confidence. I would try to help or spend some time in explaining this patient that why he needs to take these drugs. If he's someone who kind of sees me once in a year or so, I believe that confidence levels may not be there in believing me whatever I'm suggesting. So if there is a physician who he follows, probably contacting him or getting the patient into confidence, I believe is the most important thing here. And if I once I have the confidence, probably implementing these things will make sense. So the goal will be irrespective of the patient status. Even though he is in class 1, he will still require a change of medication. Existing drugs needs an hike in the dosage, and few other drugs, mortality reducing drugs, need to be included in his prescription. And most important thing is to get the patient confidence so that whatever changes have been done, actually he complies to the medication, because these drugs will prevent the negative remodeling and thereby improve the outcomes on a long-term basis. This is how I will approach this case.
So Praneeth, one clarification and then one question. The clarification is that he is not on beta blockers right now. The only thing that he is on technically is just Vimeda. He is not on anything else. That is the clarification. The other thing about this patient's confidence in you is primarily related to the fact that he is an outstation patient. He stays somewhere in Bihar, and he doesn't trust the local doctors, and for him to come to you for a regular checkup is very impractical. So it's kind of a difficult situation where he doesn't want to see the local doctor, but then he cannot come every month or two for dose adjustment to you. So that is his practical problem. My question to you is, how many drug regimen changes you are willing to do this visit, understanding that he is symptom-wise, he's absolutely fine. Like, the basic saying is, don't fix something that is not broken. For him, things are not broken. So how many changes will you do to make sure that that at least the changes itself does not trigger any unstable syndrome? And secondly, you mentioned about gaining confidence. In this kind of situation, anything that you can do to prove to him that he's still not at the perfect position and that he should be more amenable to medication, like, I don't know, stress test, whatnot. Is there anything that you can do other than pointing EF of 40% to him?
So getting the confidence, what can I do? Depends on how much patient can understand and whether he use infographics. If the patient can understand some of these things, I will try to go to internet and get some images or infographics to tell the progression of heart failure or the progression of ejection fraction or heart failure. How does it program over a period of few years, and irrespective of their symptom status, few things which infographics can gain the confidence. Do I rely on any investigations to support it? Probably the investigations are okay. It's only the action that needs to be done. And lastly, what changes to be done? Yes, I said so many, but if I have to start with one, maybe the two changes which I can look into is probably adding an SGLT2 inhibitor, which may not be much of an issue for him. With usually SGLT2 inhibitors are well tolerated with minimal side effects. So I would add that. I will not be hesitant in adding that, and maybe start with a low dose of beta blocker as well. These are the two changes that I will do. Adding an MRA for a patient with an ARNI and equal increasing the dose of ARNI requires monitoring. If I do not have the confidence that he will be monitoring his blood pressures, checks his creatinine or potassium, I will be hesitant. So because he stays outstation, probably if I have to make two changes, one adding a low dose of beta blocker and two adding an SGLT2. These are the two changes which I will do in this visit. And I'll ask him to take the help of the technology. With the COVID thing, we are used to doing the so-called WhatsApp consultations, video consultations. I would try to take the help of these things where he can get the investigations done and WhatsApp me the reports, and then I can monitor him, encourage him to check the invest in buying a BP machine and check the BP, and equally that can help. This is how I would. These are the two changes which I will do in this case.
Thank you, Praneeth. I'll move on with my attendees for their opinion. So Dr. Vijay Reddy is here with us. Sir, how would you take up this particular case? And I'm again emphasizing the same thing. Patient who is, at least what he's reporting, he's doing absolutely fine, no symptoms. He's happy with his medications. Do we have a compulsion? Do we have a medical compulsion to put him on goal-directed medical therapy, or can we work on symptom-guided therapy? And how would you take up situations like this? Sir.
Good evening, Anoop, and all of the attendees. Here is a 58-year-old gentleman who underwent CABG with severe LV dysfunction, who is a diabetic. Earlier, he is having severe LV dysfunction. Now his EF was 40%. Now he comes under heart failure with mildly reduced ejection fraction and the new ESC guidelines. And he is taking dual antiplatelets beyond 1 year. I don't know the rationale of giving dual antiplatelets beyond 1 year in post-CABG patient. That too, clopidogrel of 150. 75 milligrams is sufficient. Only in some non-responders we can give 150 mg. That's the number one. The second thing is his LDL was around 78. I recommend his LDL should be less than 55 in this patient. Number two. Number three, his heart rate was 81. In patient with heart failure, the heart rate should be less than 70. That's an ideal recommendation. So we should give adequate dose of beta blockers. What is the dose of statin he's taking? I don't know. You should take 80 milligrams of atorvastatin or rosuvastatin, 40 milligrams. He requires a mineralocorticoid antagonist. And for a diabetes patient, especially with reduced ejection fraction, you should take definitely SGLT2 inhibitors rather than vildagliptin, the combination. And you should take only single antiplatelet drugs, Vimada, MRA, SGLT2 inhibitors, high dose of statins, beta blockers. If the heart rate is still high with the beta blocker, I will add a evaporatin. But with beta blocker, his heart rate should come down to less than 70. So single antiplatelets, Vimada, MRA, high dose statin, beta blocker, and SGLT2. These are the and regular checkup of renal parameters and electrolytes. That is my take on this patient.
And sir, you would make all those changes this visit, or would you go one at a time?
One at a time.
One at a time.
Because he is not taking any SGLT2 inhibitors. They are definitely indicated with 40% of EF. That too is a diabetic, and he is not taking MRA, and he is not taking beta blockers. And I'm sorry to say one thing, because most of the patients who underwent CABG, they don't follow with cardiologists. They will follow with surgeons, and surgeons are hesitant to put high dose statins. And I'm not talking anything about negatively about the surgeons. The general feeling is like that. But all patients, they need in these patients, the target LDL should be less than 55.
Thank you, sir. I hear you. In fact, this patient, surgeon did put him on rosuvastatin 40 milligrams. That is there on his medical chart. It's just that he claims he's not very compliant with his rosuvastatin. He's compliant with other drugs, but he says rosuvastatin maybe a couple of times in a week he misses, not out of schedule, but he just kind of feels that okay, he's taking enough of cholesterol medication. But he is technically on 40 milligrams. I believe his effective dose, if you take his compliance into account, is probably going to be around maybe somewhere between 20 to 30 milligrams daily, if we take his compliance into account. I have learned that if a patient says he's missing 2 days a week, my guess is he's probably missing 3-4 days a week. That's just my guess. But on paper, he's advised 40 milligrams of rosuvastatin. Okay, let me move on to my other attendees. About the DAPT, sir, that is again something that we can discuss. If we go by the guidelines, definitely there is no indication of DAPT 1 year post bypass surgery. But in the guidelines, there is no recommendation for DAPT post 1 year of stent as well. But I think a lot of us, we tend to over-treat, not under-treat. And the role of 150 milligrams of ecosprin or clopidogrel, that is, of course, something which is not established. The role of dual antiplatelet is again something that that we have various thought process. Okay, Dr. Shankar, if this patient had to come to you, my understanding is by this time, patients do have established with their cardiologist, but it happens very frequently where they tend to follow up with their general physician for routine assessments. And a certain degree of inertia exists in non-cardiologists where if the patient is okay, then we tend to stick on the same medication. And I'm still not very confident of the what do you call, of the aggressiveness of heart failure medication in a patient who has class 1 symptoms. So Dr. Shankar, how would you take this case if this patient were to come to you for a follow-up?
Good evening to all. This patient, in spite of this left ventricular ejection fraction 40%, but is still stable and NYHA class 1 only. Here, as a diabetologist, I see many cases of diabetes in my clinic. So vildagliptin, I change here because vildagliptin has got no CV outcome trials. So vildagliptin also associated with some, it is most of the diabetics associated with the NAFLD, fatty liver disease and non-alcoholic fatty liver disease. And so this vildagliptin is contraindicated in liver disease. So I stopped giving vildagliptin. Instead of that, which has the very good molecule there in the is a 4th or 5th pillar in the management of heart failure is SGLT2 inhibitors. And now the price is also has also come down. And now it is available at 8-9 rupees. So dapagliflozin, 10 milligrams we can add here instead of vildagliptin OD. It will act in many ways. It combats the diabetes, it protects the kidney, and at the same time, it is a very good agent in management of heart failure. So second, here the almost a beta blocker really in the management of ischemic heart disease. It is a cornerstone. It's a pillar, foundation of in the chronic heart failure. It is should be given because it reduces the sympathetic overactivity, which causes progressive damage of the myocardium. So beta blocker in any cost, it has to be added to this Vimada. In this case, beta blocker, SGLT2 inhibitor, and the ARNI. These 3 drugs at present. Only thing is I added only SGLT2 inhibitor instead of vildagliptin. Then a beta blocker. We can start low and go slow till he gets a tolerable dosage, and at the same time controlling the heart rate less than 70. This is my regarding this LDL cholesterol. Suppose we can add ezetimibe 10 milligrams to this to achieve less than 55 milligrams per deciliter of the LDL cholesterol. So all these things cannot be done at a time, but slowly we should convince him that this is a guideline directed medical management, GDMT, and this is a patient centric also. It at the same time it's a disease centric also. So I personally convince him that instead of vildagliptin, SGLT2, only thing is only beta blocker is added. MRA, keep it little away, because when you combine ARNI with the MRA, then there will be hyperkalemia, then hypotension, and so many problems will come. So we have to strictly, and there may be serum creatinine may be increased also. So I strictly I add only SGLT2 inhibitor and beta blocker now, and if he is adherent or compliant with the rosuvastatin, then we'll check the lipid profile after 1 month, after 3 months. Then we will add ezetimibe in that next visit. And regarding the antiplatelets, he can be on single antiplatelet because CABG more than 2 years. So single antiplatelet agent can be given. Thank you.
Thank you so much, sir. The floor is open for discussion. If there is anyone in the meeting who wants to share their thoughts, they are welcome. The discussion points are, again, a few. Number one, changing medications in a patient who is stable. And so far, we heard opinion from 3 people here. And all 3 of them, they suggested that we should aggressively make changes to his regimen rather than maintaining the status quo. The dual antiplatelet agent, that discussion also, 3 out of 3 have said that they would back off on a single antiplatelet agent. And then the SGLT2 inhibitor, I think there also seems to be consistency in terms of adding SGLT2 inhibitor, or at least replacing vildagliptin with SGLT2 inhibitors. And with the practical scenarios taking into account, dapagliflozin becomes the standard therapy because of the cost associated. As we all know that that drug, that molecule has become cheaper as compared to empagliflozin, which one can argue may have a slightly better data set, but I think it's a class effect. So it probably wouldn't matter whether we choose EMPA versus DAPA. What I have also understood from the discussion so far is that mineralocorticoid receptor antagonist should be added, although whether to add it this time or whether to add it later on, that is something that can be discussed. With the logistic issue, it may make sense to first add a few and then check how the hemodynamics and the blood markers work, and then later on bring him back for another aspect. That is all that I've heard so far. If anybody wants to add anything to the discussion, please feel free to do that. And while you look into it, I will ask Somaraju sir for his opinion, since the discussion does not seem to have any other second opinions going on. So I'll ask Somaraju sir what he would suggest for these kind of cases, and maybe if we don't have a lot of discussion going on, we can close a bit early today. Somaraju sir, how would you take up this case?
Thank you, Anoop. Good evening to everybody. Not much to add except number one, you must talk to your surgeon and tell him that they should take the help of cardiologists or physicians. Number one. Number two, the patient living far away, like in Bihar, these days now we learned how to do it online, and you should be able to follow them up well without their coming to you all the way. And And also make it a point that any diabetic patient on metformin long term and you have vascular disease, follow up on B12. That's important. Thank you.
Sir, one question that I will ask you, which I asked all the attendees is, in these kind of patients who are class 1 in their symptoms, ejection fraction of 40%, I'm just trying to be devil's advocate. Are we really compelled to institute goal-directed medical therapy?
Here, symptoms in coronary artery disease are highly unreliable and deceptive. And presence or absence of symptoms, the degree of physical activity, and even with physical activity, ejection fraction is not equivalent to heart failure, number one. Number two, the ejection fraction, the over-reliance on ejection fraction beyond a point is also not right. But that's what we have today easily. And somebody who has LV dysfunction is around 40%, it may be less than 40 or slightly more. You should be related, you should manage him directed to his ejection fraction, his previous bypass surgery, diabetes, and objectively, rather than go by so-called symptom directed. Symptom directed comes in when heart failure is uncontrolled, he has angina and other issues. And symptom directed is not a right way to deal with a patient like this.
Sir, do you foresee any role of doing cardiopulmonary exercise testing in these cases? Because what you said is very explicitly followed in heart transplant world, where patients who are deemed end-stage heart failure, the transplant world does not go by ejection fraction, but rather go by peak oxygen consumption, where the overall idea is that any person who's consuming more than 15 ml per meter square per minute of oxygen, they are considered to be okay regardless of their ejection fraction. Can we use cardiopulmonary exercise testing data, first of all, whether we should do in these kind of patients to get their confidence, and second, can those data be used to guide therapy, or you think patients should be on therapy regardless of what the cardiopulmonary exercise testing suggests?
The patient should be on therapy first anyway. And the tests you suggested are not routinely done and are routinely available, and the cost is also an issue. You should keep that in mind. If you have routinely available test like what you suggested and the cost is not an issue, particularly in individual patients, you should be willing to do it.
Perfect. Thank you so much, sir. Any other questions, any other discussion about this topic that we can have? If not, I think we have a very consistent answer about this particular patient. So I even advocate to close a bit early. Praneeth, what do you have?
Yeah, in addition to whatever we discussed, I think one thing that we missed was vaccination. This also should be considered as an opportunity to introduce the importance of vaccination. Right now, for patients, I advocate 3 vaccines. One, the current COVID-19, which most of them are already vaccinated because of government mandate. The other 2 vaccines are being influenza and a pneumococcal vaccine. Telling them the importance of this vaccine and making a chart is something which is important because these do prevent hospitalization, heart failure hospitalization, and we know that each and every heart failure hospitalization increases their or decreases their chances of survival. So this should be taken as an opportunity to introduce vaccination as well to this patient.
Perfect. Thank you, Praneeth. So I will tell you what I did with this patient. I did check his B12 level. His B12 level was more than 500. I actually did not put him on any B12 supplementation. He did not undergo a stress test. I didn't suggest him to undergo. He was 2 years post-bypass surgery, and typically, if I have to do a stress test in an asymptomatic patient, I definitely don't do before 5 years, and even after 5 years, I do it in selective cases. So what I did on him is I did change his dual antiplatelet to single antiplatelet. I put him on a clopidogrel only drug regimen. I continued his rosuvastatin 40 milligrams because of his non-compliance issues. I told him that you take rosuvastatin 40 milligrams daily, at least for 3 months. And then after 3 months, based upon his LDL level, we can either escalate the therapy to add ezetimibe or do something else. I did check his liver function test. Whenever there are patients who are on these high doses of statin, I do check their liver function test. In the most recent recommendation, so the story of liver function test and statin, when I was in my training at that time, we routinely used to check SGOT and SGPT every 6 months in patients who are taking high dose statin, definitely in patients who are taking this high dose statin. But if you look at the recent standard operating protocols, there is no solid recommendation of checking LFT levels, and they advocate doing it based upon clinical suspicion rather than standard mode of therapy. Having said that, in patients who are on these high doses of statin, I do check their LFTs once a while, probably not every 6 months, but if the medical opportunity comes, maybe in a year or two, to make sure they don't have any occult hepatitis kind of picture. So I did check his LFTs, they were fine. So I was happy, comfortable with rosuvastatin 40 milligrams. I did add a low dose beta blocker on him. I put him on 25 milligrams of metoprolol succinate because I didn't know how he's going to behave. And as what Dr. Shankar said, for beta blocker, we go with this approach of start low, go slow. This is in contrast to the ACE inhibitors, ARB, where we can go a little bit faster. But beta blockers, we tend to go slow. So I put him on a 25 milligram dosing to escalate as and when required. I continued Vimeda at 100 milligrams right now because I'm already adding beta blockers, so I didn't want to make more changes to that. I did not add mineralocorticoid receptor antagonist at this time. Rather than replacing vildagliptin, I added SGLT2 inhibitor to his current regimen because his A1C anyway was 7.3, so I thought he can tolerate. And as we know that SGLT2 inhibitors are approved in heart failure patients, even those who are not diabetic. And his current diabetic regimen did not have sulfonylurea or any other drugs that would put him at a high risk of hypoglycemia. So I thought adding SGLT2 inhibitor to the current regimen was not a bad option. Now, in my clinic, the way I manage heart failure, and I'm sure each one of you have your own way of doing it, we do have patient educational handout, which has been custom made by us. They are custom designed and printed based upon what we think our patients should get. And we do have a dedicated line where patients can report their symptoms and they can do a follow-up. We also provide them with a printed logbook of their vital parameter assessment, which includes blood pressure, pulse, weight, and those kind of things. And what they can do is these patients, when they go home, they periodically monitor themselves. We teach them, it's in the handout, how to monitor themselves. And once they monitor themselves every month, they give us an update. And based upon those updates, we titrate their medications as and when required every month. Because he's an outstation patient, we told him to do a video consultation every 3 months till we achieve target medical therapy. And we have an inpatient, in-person visit somewhere between 6 to 12 months where somebody can physically take a look at him, examine, and do any necessary investigations as and when required. I did offer him vaccination. He had been COVID vaccinated with 3 doses. So WHO and CDC says that influenza vaccine and COVID vaccine can be taken at the same time. In India, there is no such recommendation. And I always tell my patients that if you have taken a COVID vaccine, you wait for a month before you do influenza vaccine. I don't have a scientific way to back it up. In fact, science would suggest you can take both at the same time. He took his COVID vaccine literally on the day when he came to see me. So that was his 3rd dose. So I told him that wait for a month and then he can go for a quadrivalent influenza vaccine for 2022 strain, that he can do it in his hometown, that is in Bihar. So that is the recommendation I did for him. Anybody is free to comment on the treatment modality that I suggested. And as I said, if there is no further discussion, that we can close. Shankar sir, you have something to add?
Only thing is, when we come across such patients, we should advise them not to use NSAIDs. That will worsen his situation. And especially few of the diabetologists not knowing, they may put him on thiazolidine-diones, that is the pioglitazone or rosiglitazone is out of market, but pioglitazone still it is there available in the market. So that will increase the sodium and water retention and increases the heart failure. So thiazolidine-diones are contraindicated in this case. NSAIDs should be avoided. And most of the times, many of us have burnt our fingers using CCBs, especially this non-dihydropyridine CCBs like diltiazem, the verapamil, which has got a negative inotropic action that will increase heart failure. So these cardiotoxic drugs should be avoided as far as possible. And one more thing to be added is the thyroid profile has to be done frequently, at least once in a year, so that we can find out whether it is hypo or hyper, which can be well treated, and it is a reversible cause for the progression of the heart failure. So this, and at the end, I would like to know from the audience, and especially Dr. Somrazu and Dr. Anoop Agrawal, that regarding this newer drugs which have added to our armamentarium in the management of reduced ejection fraction, like the cardiac myosin activator, the omecamtiv mecarbil, and the soluble guanylate cyclase stimulator, Versic. These have been added, actually approved also by FDA. What is your experience? Just I want to know from you.
So Shankar sir, I can suggest that basically all these drugs, you mentioned vericiguat, and then you mentioned the actin myosin
omecamtiv.
Yeah. So none of these drugs are available in India. Let's make it very clear. So I don't think that we have got a direct experience of using those drugs. Vericiguat was approved by US FDA for heart failure with a very narrow margin. And if we go back in time, then Arni, which is Entresto, which was marketed as Entresto in US at that time, even that had a very, very slow take amongst cardiologists. So was SGLT2 inhibitors. I think that the space of heart failure is a little bit more rigid as compared to other pathologies. And nowadays, where SGLT2 inhibitors and ARNI have become a standard of therapy, early on, these drugs faced a lot of inertia amongst cardiologists, partly for the reason that we are discussing today, and that is when patient is feeling fine, why to unnecessarily tinker with their medication? That was the whole thought process early in the day, which even continues now, particularly for newer drugs. For established drugs, they are still okay. My colleagues in US, they still have not adopted to vericiguat that much. I'm pretty sure in India, none of us have used because it is not available at this point of time. Once it comes to put this drug in addition to the standard goal-directed medical therapy, which we discussed right now, that certainly is something that we should look forward to. But at this time, I don't think any one of us have got any personal experience using it. And even in US, the doctors don't have that robust experience using other than the clinical data that we have to go by. We'll have Somaraju sir for his opinion on this. Yes,
Dr. Shankar, as Anoop said, I have no experience with these drugs, obviously. But having said that, I just wanted to say that in heart failure, we have already a problem of polypharmacy and poly-device therapy already available. And polypharmacy is so much that if you go on adding up the benefits, survival benefits that are published in the literature and clinical trials, whatever it is, one of the drugs, each of the drugs has 20, 30%, 15% benefit. And then devices have some more benefits, to the extent you almost start wondering whether it's better to have heart failure than not to have heart failure. And they made heart failure a heart success by all these polypharmacy and poly devices. And it's very confusing beyond a point. Don't increase the number of drugs unnecessarily, because there are already too many things. Thank you.
Sir, I agree with you. I think that this heart failure and polypharmacy is certainly something that we should seriously take. It has got both the pluses and minuses. We know that the overall outcome of heart failure currently is dramatically changed. The spectrum of heart failure, what patients feel, how much do they survive, that all has been dramatically changed with the advances in medical therapy. And in fact, when somebody says TAVR for aortic stenosis or coronary angioplasty for coronary artery disease and whatnot, I believe the biggest advancement in the field of cardiology in the last 2 decades is in the field of heart failure, where we have learned so much about the disease and we have got so much of options in our armamentarium. Having said that, we should look into the impact of polypharmacy as well. But even if you take a modest 20% incremental mortality benefit of individual drugs, when they are studied in the randomized trial, the numbers would say 30-40%. But even if you be modest and take 20% as the incremental benefit, certainly the heart failure longevity has doubled, if not more than that. And the symptom control is also quite remarkable. So definitely these drugs, they have changed the overall spectrum, but to ignore the aspect of polypharmacy, that will be totally wrong as well. So mentioning about not taking NSAIDs or not taking any other irrelevant medication, trying our level best to reduce all the other less important medications, so that or redundant medications, so that patients don't pop in 20 tablets a day. Unfortunately, patients who have coronary artery disease, diabetes, and heart failure, they anyway are taking more than 7-8 tablets a day. That is the unfortunate part of it. But they do help. And one more thing, that there was a fascinating study by non-clinical scientists in the United States, where they looked at what happens when you add a drug or a 5th drug or a 6th drug in a patient's armamentarium, not related to heart failure, but related to polypharmacy as a general. Remember, when these drugs are studied for their adverse effect profile, they are not studied in these patient subset who are taking 5, 6, 7 medications. They are studied in pure patient subset. In their phase 1 and phase 2 data set that they acquire, these drugs, they are studied sometimes in healthy subjects and then sometimes in disease subjects who are not with all these medication, let alone aggressive medication changes. So how one medication interact with a human body in the absence of any other medication versus in the presence of 4 or 5 medications already, that I don't think anybody knows. The post-marketing surveillance, we all know, in countries like India virtually does not exist. And even in countries like US and Europe, they are not as robust as the data set up to phase 3 clinical trial. So the issues regarding polypharmacy is real. We definitely should be paying extra caution when we are giving our patients more than 3 or 4 medication. But having said that, we also have to appreciate what these medications have brought in life of a heart failure patient.
I just want to add one thing, Anoop, if you agree. Any patient above 60, 65 years, if you give more than 5 drugs, the drug interactions are so much that some of them it harms. Thank you.
Absolutely, sir. And I think that is the point that we are trying to discuss, that when you add more drugs, definitely you are inviting more trouble. But that should not preclude us from not treating patients. We should treat patients. We just need to be cautious of what we are doing. We need to be mindful of what we are doing. That is the point that I think is worth looking into. Okay. Any other questions or discussion about today's topic that we can put forth?
Excuse me.
Yes.
In the patients of a heart failure, we regularly ask for BNP or NT-proBNP, but especially the patients who are on ARNI, there will be erratic report with the BNP because the neprilysin degrades the BNP, so that the neprilysin inhibitor usage, so it will increase the BNP levels. So that's why we have to ask only for NT-proBNP, which is unaffected by the ARNI. This is, I want to bring it to the notice of August audience.
Right, sir. I think that is a very, very relevant point and quite important, that the whole molecule BNP is not to be tested in patients who are taking ARNI. We should be testing the submolecule that is NT-proBNP. Absolutely. Okay, any other thoughts, question, comments? Praneeth, your closing comments for today's discussion?
Yeah, so a fairly common topic, and I'm glad most of are in agreement on modifying the therapy irrespective of the patient's stable condition and in class 1, and the highlighting the importance of various drugs in the benefit of heart failure with reduced ejection fraction, highlighting the importance of secondary prevention of ASAVD, targeting the lipid goals, hypertension goals was well highlighted, and we equally need to understand the problems with polypharmacy, try to reduce them as much as you can, avoid unnecessary medications, and keep them as little as possible, and engage the patient in discussion, educate them about the importance of heart failure, which helps in adhering to the therapy, and they are involved in their own care, which goes a long way in patient management.
Perfect. Thank you so much, Praneeth. And I thank all of you for joining and participating on a national holiday. These kind of discussions, they help us treat our patients better, certainly in a more informed way, and definitely in a more scientific way as well. So I appreciate your time sharing your thoughts with us. As you all know, we do weekly huddle discussion every week, and we'll be back next Wednesday with another new topic. That will be at 7 p.m. Thank you all for attending today. Good night, and we will see you next Wednesday. Good night.